Our speaker, Dr. Jacob Appel, is an American author, also a poet, a bioethicist, a physician, a lawyer, and a social critic. He is best known for his short stories, work as a playwright, and his writing in the fields of reproductive ethics, organ donation, neuroethics, and euthanasia. His novel, The Man Who Wouldn't Stand Up, won the Dundee International Book Prize in 2012. He completed a bachelor's degree at Brown with a double major in English and American literature and history. He has 7 master's degrees: European history from Brown, in American history and philosophy from Columbia, an MFA in creative writing with a focus on fiction from NYU, an MS in bioethics from Albany Medical College, an MFA in plain writing from Queens College, and a master's of public health from Mount Sinai School of Medicine. That's not enough. He holds a JD degree from Harvard Law School and his MD degree from Columbia University of College and Physicians. He completed his residency and fellowship at Mount Sinai Hospital in New York City and is a practicing psychiatrist there. He's also licensed to practice law in New York and Rhode Island, and was the subject of a 2019 movie entitled Jacob. And after communicating with him several times, I could also say he's quite modest and down to earth. So I look forward to the talk. Take it away, Jacob.
Thank you. Thank you for having me. I am going to start my stopwatch now so I don't take more than an hour of your time, because the most important thing you learn in medicine is that if you speak for an hour and 1 minute and you are brilliant, all people will remember is you stole their minute. But if you speak for 59 minutes and you are terrible, people will say, he wasn't that bad and he got us out on time. So with that, I really appreciate the introduction. To my mother, however, I am still her son who's not the rabbi. Maybe as humanist, you can appreciate that, which is better than what she used to say, because she used to say he's a psychiatrist, he's almost a real doctor. So we're moving in the right direction. I'm going to share my slides if you give me 1 moment. There we go. Can you all see my slides? Get a thumbs up from Don, maybe? Perfect. And everybody can hear me. Great. So I'm going to talk about COVID-19 ethics as they relate to resource allocation, which is one of the areas I study. But to do that, I got to talk a bit about resource allocation in times before crisis, so we can do some comparison and ask the right questions. So the 2 questions I want to ask today are, how should healthcare resources be allocated in non-crisis situations? And then how should this calculus change during a widespread emergency, like, for example, the COVID-19 pandemic? Bioethics is really about asking the right questions. So the COVID-19 pandemic has forced us to ask a lot of hard questions. But one thing to think about is why we didn't ask those questions in the past. Why haven't we asked complex questions about resource allocation earlier? What has this made us see that we otherwise weren't seeing? I do want to begin with a joke. And I tell you it's a joke in advance because I'm a bioethicist, not a comedian. And if I didn't tell you it was a joke, you might not realize it was. But it serves a pedagogical purpose. So 2 Mount Sinai professors retire and they go off to Yellowstone National Park. And on their first day there, they want to go for a hike in the woods. And the park ranger comes out in his park ranger cap and he says, "Gentlemen, I have to warn you, this is a legal disclaimer from the Park Service. There are bears in the woods, and in theory, a bear could eat you." And the first Mount Sinai professor says, "We'll take our chances. We've dealt with medical students." Second Mount Sinai professor says, "Give me a moment," goes back to his cabin, returns a few minutes later with his Mount Sinai jogging shorts and his Mount Sinai running shoes. And the first professor says, "Are you out of your mind? You can't outrun a bear." And the second professor says, "Of course not, but now I can outrun you." I get a smile. The point being that in resource allocation, rarely are we going to outrun the metaphorical bear. Rarely is there an ideal choice to make. Instead, we have to choose among least best desirable outcomes. And keeping that in mind, a lot of what bioethics and resource allocation is about is storytelling. Flannery O'Connor, the famed American short story writer, used to say there are only 2 plots to short stories. A stranger comes to town and a person goes on a journey. But if you think about them for a second, they're really the exact same story told from 2 different vantage points. And a lot of the stories issues I'm going to raise today When you try to tell stories or set narratives about them, which vantage point you stand in determines what outcome you come to. As background, there are three types of scarce resources in the world. There are things for which there's a hard scarcity. The most concrete example of this would be solid organs. We could change the organ donation system in complex ways, and over time, we might have more organs available. For example, switching from a opt-in system to an opt-out system, or imposing a mandated choice system. That would take both political capital and a considerable amount of time. Trained professionals, the same principle applies to. Pediatric neurosurgeons. We could increase the number of residency and fellowship slots for neurosurgeons and pediatric neurosurgeons, but it would take a generation to vastly increase the number available. Then there are soft scarcities. These are things for which, with a fairly small shift in energy, we can achieve different distributions of resources. And the most concrete one of these is healthcare expenditures. Now, you still need the political will to make the changes, but if the legislature decides they're going to raise taxes and spend more money on healthcare, we add more money on healthcare. Fungible. And finally, there are evaporating or conservable resources. And the most iconic of these are antibiotics. Up to a point, antibiotics are highly effective at treating bacterial infections. But if we start using them excessively to treat viral infections or to promote growth in livestock, eventually they will no longer be effective. We will hit a tipping point. As long as we conserve them, some might say the planet applies the same way. As long as we conserve the resources, we do fine and they replenish. And when we don't, we hit the tipping point and they fail. Now I want you to think back to non-crisis times. I know this is hard for some of you to imagine. That was a concert. Down on the bottom right, that is a restaurant. On the bottom left, that is a sporting event. Someday you will tell your grandchildren or maybe your great-grandchildren what these were. In non-crisis times, it's important to think of three kinds of allocation and then how those types of allocation affect people during crisis times. So the first concept of allocation is macro allocation. That's the big picture question. That is, how should our society as a whole allocate resources? So in the United States, last year, we spent 17.9% of our GDP on healthcare. My guess, by the way, is it's going to be much, much higher this year, not necessarily because our healthcare expenditures go up, so much as that our GDP may go down. But give you a sense, the range in the US is somewhere between 17 and 18% for at least the last decade. That is about 3 times as much money as we spend in education. And if you look down at the bottom right, that gives you a sense of what percentage of GDP other developed nations spend in healthcare, and you can see we spend a much larger percentage. That doesn't tell you, by the way, whether our system of healthcare management is a better one or a worse one. The problem is when you compare, for example, you will hear people say, well, they have national healthcare in Great Britain. People have to wait online. But it isn't the National Healthcare Service in Great Britain that forces people to wait online. It's the fact that they spend a much smaller percentage of a much smaller pool of healthcare dollars on healthcare resources. So until you spend roughly the same amount of money, you really can't compare single payer national insurance programs and private insurance systems. Macro allocation during non-crisis times significantly affects how we allocate resources during COVID. How? The healthier your society is at baseline, the fewer resources you're going to need during times of crisis to treat people who have acute conditions. And COVID is a perfect example. There are vulnerable conditions, brittle diabetes, hypertension. If you treat those during normal times or during non-crisis times, you'll have far fewer people who need ventilators during crisis times. This actually matters to you if you're a very healthy person, because you might say, I'm a very healthy person. I live in an upper middle class community. I have very good health insurance. Why do I care whether low-income people in poor communities get health care or not? And the answer is, when there's a crisis, they're going to need a ventilator. And if there are more patients in their community who are sick, they're going to need more ventilators, and you're going to have to compete with them on the market, so to speak, for those ventilators. One of the explanations for the crisis we see in healthcare today that you often hear about in terms of cost, and I'm not telling you whether 17 to 18% is too high or too low, but I can tell you why it is where it is. And this was the research done by a healthcare economist named Lester Thoreau, who explained that Americans at their baseline are both libertarians and egalitarians. What does that mean? It means, on the one hand, if there's anybody out there who can afford a particular healthcare intervention, costs millions of dollars, but Bill Gates, Warren Buffett, somebody can pay for it, we don't feel comfortable as libertarians, telling them we're not going to let them do that. Some European countries do. Some European countries say you can't buy it on the market, which is why their well-off citizens come here. However, once we say to people it's available to some, then the communitarian or egalitarian spirit in our culture says, then we need to pay for it for everyone, which is why healthcare expenditures go up. The other thing to think about is how we allocate resources in peacetime in terms of insurance. And this man, William Hammett Davis, is probably the most important man in the history of American healthcare. And my guess is that nobody here has ever heard of him. Anybody who has heard of him can put his name in the chat box, tell me what he did. You will get a free virtual lunch. No one ever does without looking it up. William Hammett Davis was the head of the War Production Board during World War II, a man who had nothing to do with medicine and yet was more important to our healthcare than Jonas Salk. Why? Because during World War II, there were price and wage controls. And the question arose whether fringe benefits like health insurance would qualify as part of your salary for the purpose of salary caps or salary controls. And he said the answer was no. So companies in the United States, they couldn't compete based on salary for employees, started competing based on benefits. And that set the trajectory, and many of these benefits were untaxed, to what became known as Cadillac healthcare plans. They were called Cadillac healthcare plans because Cadillac was, as most of you probably know, General Motors' high-end vehicle, and General Motors had one of the most extensive healthcare plans in the country, so much so that by the early 1980s, when General Motors was on the verge of bankruptcy, it had become a giant healthcare concern. Whose primary purpose was providing health insurance for its retired employees that also incidentally happened to manufacture automobiles. You're seeing the same phenomenon, by the way, in a lot of municipalities today, where fire departments let employees retire at 40, assuming that their life expectancy would be 60. But now their life expectancy is 80 or 90, and the insurance adjusters in the actuarial tables haven't accounted for this. And municipalities are becoming giant health insurers for their retired employees that also happen to provide police services, fire services. But not an easy solution to that, because you don't want to have a 75-year-old firefighter or an 80-year-old police officer running into your building. Secondly, we need to talk about mesoallocation. Mesoallocation is the amount of money we spend on particular aspects of the healthcare system. That could be research, it could be prevention, it could be acute care. And it's important to remember that where we spend money in this system during non-crisis times also affects where we need to spend money during crisis times. So if we spend a lot of money on research preventing pandemics, we'll need less money to treat acute patients during pandemics. So many of you probably remember the Ice Bucket Challenge. The Ice Bucket Challenge, which is now, I think, more than 10 years old, was designed to raise money for ALS patients. Anybody want to guess how much in the first year it raised? I don't know if I can see the chat, but we feel brave. I hear no brave answers, but I can at least hear. Maybe somebody's typing them. Oh, I can't see the chat with my screen sharing. But the answer is about $100 million. Now, $100 million may seem like a lot of money. But to put that in perspective, that same year, Americans spent $200 million on Halloween costumes for their pets. Now, that is worth thinking about. That gives you a sense of where our priorities are. And I will show you in 1 second, there are few items in our preventive medicine budget that get fewer resources than pandemic preparedness. So the third kind of allocation you want to talk about is microallocation for individual diseases, for individual demographic groups. And this gives you a chart of which diseases in the United States are overfunded and which ones are underfunded by two different measures. Those on the upper left are overfunded, above and to the left of the blue line and green line. Those to the bottom right are underfunded. Two things to think about. Historically, both breast cancer and HIV were underfunded diseases. They have, over the last decade or so, become overfunded diseases in relation to the number of quality-adjusted life years saved. In contrast, on the bottom right, mental illness, which is my field, is substantially underfunded year after year. Why is that? Because if you're a politician, there's nothing easier to cut than the mental health budget. Mental health patients rarely can advocate for themselves, particularly those with severe mental illness. Their family members are often, for various reasons, are reluctant to advocate for them. And the consequences of not funding mental health often occur long after that particular politician has left office. So you deinstitutionalize people in the 1980s, and they live on the streets in the 1990s. And then in the 2000s, you suddenly have a crisis of homeless individuals with severe mental illness. But most importantly, because that's the subject of today's talk, pandemic preparation, which I have been talking about long before COVID, even before swine flu, for the last 15 years, is consistently at the far bottom right in terms of the number of lives saved and mistakes involved in relation to dollars spent. Just to give you a sense of how the microallocation plays out and how there are underlying biases involved, I've chosen two iconic illnesses associated with particular racial groups. So even though it is possible to be African American and get cystic fibrosis and possible to be white and get sickle cell disease, both on average and more importantly in the public consciousness, cystic fibrosis is associated with white Europeans and sickle cell disease is associated with African Americans. And you can see there's an extraordinary bias in how these are approached and funded by our society. So philanthropic expenditures are significantly greater per person with CF compared to sickle cell disease. From 2008 to 2018, annual CF publications remain greater than those for CSD, even though sickle cell disease is a much more common illness. Cystic fibrosis trials were significantly more likely to receive industry funding. And when you remember my $100 million for ALS research and my $200 for Halloween costumes for pets, only $76 million for NIH funding for sickle cell disease. I mention all this because it's important not to lose sight of how our resource expenditure during peacetime affects not just overall crisis needs during COVID, but particular demographic, racial, ethnic, economic groups during a crisis. So I imagine, having spoken to many upper middle class audiences in the Northeast, that a good portion of you believe in some form either of universal health care or at a minimum that anybody who walks into a hospital should be stabilized. And that, by the way, the latter part is the law. The Hill-Burton Act of 1946, hospitals wanted to expand. The government wanted to guarantee that people who showed up in emergency rooms received care. The government made an offer to any hospital, take our money to expand, but then you have to stabilize patients. In the 1980s, that became a law known as EMTALA, which is basically a typical government bait and switch. They kept demanding the requirement that you treat patients who show up. They stopped providing the money. So all of us have some sense of what belongs in a basket of goods and services. Where we disagree, the harder question is figuring out what belongs in that basket of goods and services that should be covered. So I want to ask you which of these is a disease, and I'll tell you what they are in a second. So on the right, most people would agree that the removal of a malignant carcinoma of the breast, if you believe anything should fall under an umbrella of publicly covered healthcare for those in need, would be healthcare. But what about reconstruction of those breasts to make the patient whole again? Is that a cosmetic intervention or is that a medical intervention? Historically, that was a cosmetic intervention. Federal law and insurance programs now have made that into a medical intervention. Is top surgery or breast enhancement for patients who are transgender a cosmetic intervention or a medical intervention? So up until fairly recently, that was widely viewed by policymakers as a cosmetic intervention. Now a number of states have shifted their rules and now it is a medical intervention. And now this is the part that it shocks me every time, but I've learned from the medical students, there are restaurants that actually pay people more and hire waitresses based on their breast size. This should, by the way, disturb all of you because it disturbs me. But in that context, if I come to a provider and I say, look, there is more economic viability to get equal rights in society, I should have breast enhancement. At what point does that become medical and not cosmetic? Before you answer that question, I want you to compare that to the man on the left. The man on the left suffers from a very severe illness, which some of you may be familiar with, called male pattern baldness. Compared to the research and treatment of ALS, that $2 billion are spent in the United States alone trying to cure male pattern baldness every year. I ask you whether it's an illness or a cosmetic phenomenon. I have discovered that the answer varies significantly based on the gender and age of the audience. Often when I stand in person on a podium looking down, I can predict the views of particular individuals in the audience. But I mention that because there is a wide range of what we might consider medical versus cosmetic. I also want to mention the case of Slim Watson, because many of you who do believe there should be universal coverage of some sort for healthcare need to ask yourself, are there limits to it? And Slim is a perfect case to talk about the limits. So Slim was a prison guard in North Carolina in the year 1999-2000. And he retired, he was in his late 60s, and he noticed under his arm these unusual blotches that were hematomas. And he got concerned, so he went to the local hospital. And the good news for him, the bad news for them, was that it was the Duke University Medical Center. And he was diagnosed with a rare condition called factor VII inhibitor syndrome, I don't know if there are any hematologists on this call, but if there are, they probably know far more than I do, and they're going to wince right now. But I tell people it's a condition that is biologically different, but in both mechanism and appearance similar to hemophilia. Basically, he's bleeding under his skin and it can't be controlled. Now, the good news is there's a treatment for this disease called high-HC, and it is available from synthetic factors in pigs near Birmingham in England. And you need about a couple of days worth of it for $1,000 a dose, and 12 to 24 doses will cure you, at least in theory. In practice, there are two problems. One, and you can't make this up, there's a rare epidemic of swine flu that knocks out all the swine from which this is harvested. And the only treatment available is a more experimental treatment called Nova 7, which is now in the market, but at the time was only available from Copenhagen and Denmark and cost $12,000 a vial. And you needed a vial every hour on the hour. And most patients either got better or they passed away. And Slim neither got better nor passed away. Now, he's not like many of the iconic cases you think of in bioethics, Karen Ann Quinlan, Nancy Cruzan, who were comatose or unable to communicate, Terry Schiavo. He's bright and cheerful, wandered around the hospital. I believe they eventually got him a gig entertaining pediatric patients. The only thing he can't do is leave the hospital. And a whole industry springs up around Slim Watson that the Wall Street Journal reported on, planes bringing medication in from Denmark to North Carolina. Slim, while he'd rather go home, would much rather live like this than not live. He can take pleasure in life. Duke becomes so concerned, they actually go to Congress because they're afraid that he might bankrupt the hospital if he lives 2 years, to get Congress to pass special legislation, the Slim Watson Act, that would cover Slim Watson's medication and healthcare individually by the federal government. So his wife gets the bill after the first month. The bill is only about $300,000. She's very relieved. Then she discovers it's because the hospital's computer system can't print out the digit to the left. First bill hospital care, 1 month, $5,300,000. Now you want to ask yourself, is there a point where you say to Slim, you've gotten more than your fair share of money? Because there are hundreds of other patients in the Medicare, Medicaid system already who do cost several $1 million. Is there a tipping point? Because that costs someone else a mammogram and a flu shot in a zero-sum game. The good news for Duke, the bad news for Slim, by the way, is he died shortly after a month. Some of you have probably heard that money spent at the end of life accounts for a large percentage of healthcare dollars. So, for example, that 30% of all Medicare expenditures are attributed to the 5% of beneficiaries that die each year, with 1/3 of the cost occurring in the last month of life. Now, that is truly useless information as a policymaker. Why is that useless information? I ask all of you who are now in the last 6 months of your life to raise your hands. I'm probably going to get very few hands. Hopefully, that's because it's not true, but we don't know. Hindsight is 20/20. All of us know that on Monday morning, it is very easy to say what the quarterback should have done on Sunday afternoon. I have discovered over time there's a correlation in that, by the way, between the same people who favor funding for malpattern baldness. But hindsight is 20/20, and people always think they're going to be the tail. So if you, for example, look up ALS prognosis on the internet, or at least historically did, and ALS is a prognosis 2 years to 5 years. It's very short. The first thing that came up was not prognosis ALS 2 years to 5 years. It was a picture of that man who lived 40 years. I think it may have changed now, but over time, that's what people found. It's still way up there. You see Stephen Hawking. So you think you're going to be the tail and not the vast majority of people who don't make it to that end. If you typed in abdominal mesothelioma, prognosis, disease with an expectation life expectancy of 2 years, you get a picture of Stephen Jay Gould, National Book Award winner, 20 years beyond life expectancy. People always think they're going to be the tail, and we shouldn't deny them that hope. As a doctor, I would want to give people that hope. As a policymaker, you need to think about how that affects resource allocation. I want to mention a bit about the world's most expensive drugs. Some of you may be familiar with some of these drugs. I have never ordered any of them. I imagine if I ordered any of them at the hospital, I would get a call from senior leadership telling me to stop. They are child's play, because the world's most expensive medication is now Zolgensma, that costs $2.1 million per dose. It is a Novartis medication for treating spinal muscular atrophy. Again, you should ask, is any amount too much to treat a debilitating neurologic disease? My trivia question for all of you, you can turn to your spouse at home if you know the answer. I don't think I can ask while you're all on mute, is does people know the difference between a lottery and a raffle? Because I always thought they were the same thing, and they are not the same thing. So the difference is that it turns out a raffle guarantees a winner, and a lottery does not guarantee a winner. You go to the state fair, somebody wins the prize-winning chicken or the plate of homemade brownies. If you buy lottery tickets, sometimes it's carried over to next week. Zolgensma, the Novartis drug, and possibly the worst optical decision ever of a pharmaceutical company, they made the decision to have a raffle for doses of the drug for those who couldn't afford it. But they branded it as a lottery because a raffle did sound like something of a state fair and gave away about 10 doses a month. The problem is that there are about 6,000 people who qualify for this drug, and the cost to taxpayers, if it's covered, would be about $1 billion. That's not the really bad news. The really bad news is the Orphan Drug Act of 1983. And I shouldn't say bad news. You may think this is really good news. You may think this is really good policy. But if your goal is to save money, this is a path you don't want to tread, which is that the Orphan Drug Act favors funding for diseases that affect 200,000 Americans or fewer, creates tax breaks, fast track approval provisions, market exclusivity. Prior to 1983, there were only 38 drugs on the market in the entire country to treat conditions that affected fewer than 200,000 Americans. That's stunning today. By 2018, there were 503 approved drugs. The problem is there are about 5,000 to 8,000 diseases for which those drugs could be developed, many of them single point mutation diseases, many of them which would be treatable or curable with drugs similar to Zolgensma in a similar price range for a cost that will run into the trillions of dollars. And the question you need to ask yourself is, do we as a society want to develop those drugs at the cost of trillions of dollars and the trade-offs for other consumer goods you won't be able to have? I want to make one more comment on non-crisis times, and then for the next 30, 35, I'm going to shift over to crisis times in COVID. And that is, I want to mention the Oregon healthcare plan. I imagine you are secular humanists. If I asked you how many of you think that healthcare should be allocated rationally in the United States, I would get a sizable number of hands. I can tell you that even when you address religious organizations and ask people how many people should get healthcare allocated rationally, you get a majority of hands. Rational healthcare is something a lot of people in theory seem to agree on until they get to the nuts and bolts. So John Kitzhaber was governor of Oregon in the 1990s and actually again in the 2000s. And he was a former ER doc, and he decided he was really going to allocate resources rationally in a way nobody had before. But he also knew that the amount of money available for healthcare was not going to change in the state. I believe he had a Republican legislature. He did not have the political power to increase funding. What he could do was he could raise the ceiling on Medicare income, meaning the amount of income you needed to get Medicare to cover a large portion of low-income working class people who weren't covered. In the first year alone, the number of people covered by Medicaid, the state program for health insurance for the poor, rose from 240,000 to 360,000. But he did it with the same amount of money. So what did he do? He spread the money more thinly. The state made a list of the different things that doctors could do. They had a specialized committee. Turns out there are 694 things that doctors can do. I never knew that. They went to medical school. They never told me that. The two things that aren't covered are dialysis, which is covered by the federal government, and childhood vaccination, which is covered through other federal grants and programs. They make this list, and they cover the 492 items that are most important, meaning those that save the most lives, prolong the most lives, are most likely to improve quality of adjusted life years. You could think for yourself for a second, what are the top prioritized conditions? It's not going to be a surprise to anyone. They're things that are cost effective: pregnancy treatment, birth of an infant, preventive services for children, prevention, tobacco, obesity. You could think back to my second set of slides on meso allocation. Mental illness does really well, major depression, schizophrenia. And then there are things that do really badly in 1993. Two that I like pointing out are gender identity disorder, because that has since moved on to the funded list as society's values have shifted, and finger reattachment. If you lose your finger at this joint, you're out of luck. But if you lose it at this joint, they reattach it. That is the degree to which they've micromanaged this. That's a purely rational system for saving the most lives with the same amount of money. Here's the problem with it, or the reason people find it difficult. So its most controversial feature was they only covered cancer funding or cancer treatment, meaning non-palliative chemotherapy, radiation surgery, for patients with a greater than 5% chance are living 5 years. Some of you may think this is a good plan. Some of you may think it's a bad plan. I won't make you raise your hands. I will tell you two things. One, a woman in Oregon received a letter after her terminal lung cancer diagnosis from the state telling her they would not pay for her chemotherapy, but they would pay for her assisted suicide, her aid in dying, which led to a public backlash. And eventually she got care from a private charity. But the state's evidence may have been the proof in the pudding that she was dead within 6 months. So in some ways, their funding choices actually made sense even with the care. The more problematic question for those of you who believe in rational allocation of healthcare is, why did they choose 5%? They did not choose 5% because that's the rational cutoff. There are actually indications that the rational cutoff may be much higher, 15%, 17%, 19%, but the optics wouldn't allow that. The optics say that if you walk into a doctor's office with a 17% chance of surviving your cancer for 5 years, but we know that money can be better spent treating other people for mammograms or flu shots, no doctor feels comfortable denying you care, and very few rational thinkers do. At some level, we prefer an irrational allocation, at least at the margins or the extreme. That being said, the goal of the program was to shift care from visible victims to invisible victims, which is what I want to talk about in a minute in relation to COVID. Visible victims are people who know they're not getting care. If a state like Arizona did at one point, stops covering certain organ transplants, the patients who don't get those transplants know the state has in essence killed them by denying them care. In contrast, if you don't get a mammogram and 6 years later you die of breast cancer, or you don't get smoking cessation and 30 years later you die of lung cancer, you're an invisible victim because you don't think of yourself as being shortchanged in the same way. Now, I'd like to switch to crisis times. Some of you may remember that duck and cover drill back in the good old days. So the first major resource allocation crisis in the United States occurred during the 1940s and 1950s in relation to iron lungs. I know some of you are probably thinking that there was scarce resource rationing of antibiotics during World War II, and there was, but only at a small level because the military got first priority, and there wasn't the full accessible national rationing plan that there was for the items I'm going to talk about. Iron lungs really are the first major crisis. By the way, you can make a wooden lung at home. You can look at how to do it on YouTube if you want to, out of 4 plywood boards and a vacuum cleaner. The medical students love doing this. It works very well if you have polio. It works very poorly if you have COVID. My mother had polio in the early 1950s. When you came to the hospital for an iron lung, they were allocated on a first come, first served basis. Sort of like sandwiches, you take a number at the deli counter. Why? Because there were a very large number of people who were presenting at roughly the same time with similar levels of life expectancy. Most of them were children in similar conditions. And any other allocation system wouldn't have been able to parse people quickly and effectively. That differed greatly from the second major rationing crisis that some of you may be familiar with in the 1960s. And that was what to do with dialysis machines. And the most iconic example occurred at Swedish Hospital in Seattle in the early 1960s. And they appointed a committee to figure out, having first eliminated everybody who medically they didn't think qualified for dialysis. And just to reassure all of you, including me, I think this may apply to everybody on the phone call. If you were over than 40, at least everybody I saw, if you were over 45, you automatically didn't qualify because you weren't medically healthy enough. If you were under 18, you automatically didn't qualify because you were psychologically unable to handle dialysis. If you had any other medical condition at all, you didn't qualify for a machine. And they still had a very large number of people for a very small number of slots. So they appointed a committee, and you can see the committee there. They look like a rather imposing lot. A lawyer, a minister, a banker, a housewife, a government official, a labor leader, and a surgeon, all appointed by the local medical society. And they accepted applications. And their applications were sort of like college admissions applications. They judged you based on your social worth and your likelihood of contribution or past contribution to society. They had no sense they were doing anything inappropriate. In fact, Life magazine came and profiled them in 1962. And I will show you a brief excerpt from the transcripts, which are available online, just so that your heart stops for a second. So I need to move this so I can see it. So the housewife in the committee says, if we are still looking for the men with the highest potential of service to society, then I think we must consider the chemist and the accountant have the finest educational backgrounds of all 5 candidates. And the lawyer says, both these men have made provisions so that their deaths will not force their families to become a burden on society. And the state officials, But that would seem to be placing a penalty on the very people who have been most provident. I'm a surgeon. How do the rest of you feel about number 3, the small businessman with 3 children? I am impressed that his doctor took special pains to mention that this man is active in church work. This is an indication to me of character and moral strength. And the lawyer, in typical cynicism, it would also help him endure a lingering death. And the minister, perhaps one man is more active in church work than another because he belongs to a more active church. And finally, the labor leader, for the children's sake, we've got to reckon with a surviving parent's opportunity to remarry. And a woman with 3 children has a better chance to find a new husband than a very young widow with 6 children. And it goes on and on. I hope this disturbs some of you because it's disturbing, and it was disturbing to the American public, even in 1962, when there was a backlash. It is a portion of the reason why the federal government now covers dialysis funding. But more importantly, it's the reason we do not use social worth in making allocation determinations for scarce resources, ever. And that played a role, I will add, in our systematic assessment of COVID patients. And finally, the third pre-COVID crisis, which I was involved in to some degree, was how to allocate ventilators if it came to that during the swine flu epidemic, and it did not come to that. But let's take a hypothetical case. So you have 10 patients on chronic ventilator support in your hospital's long-term care rehabilitation unit. You have thousands of patients in the ER or triage who will need ventilator support for 3 to 5 days, with more coming. There are only 50 ventilators available for them. But the state also, in your hospital, has long-term care units, patients who've suffered spinal fractures, will never breathe on their own again, people like Christopher Reeve. Is it ethical to cannibalize those machines, in essence, kill those patients, remove them from life support, knowing that you will save dozens or hundreds of other patients with the same machines? New York State took the position during the swine flu discussion that this was not an appropriate decision to make, that these were 2 separate pools of machines, and that patients with disabilities who'd injured would in essence receive a double whammy if they were victimized again. Not all states took that approach. But that's an easy place to draw the line. I'm going to make it harder for you in 1 second. Give me 1 moment and I will get to the harder question related to that. But first you want to ask yourself, how much risk during COVID should we ask providers to undertake? That's often described as a rights of doctors question, but it really should be described as a scarce resource question. You only have so many resources in medicine. How are you going to use them? So a question I like to ask the medical students, just somewhat autobiographical. A 46-year-old psychiatrist in New York City Hospital is asked to redeploy to work as a general medical provider in an ICU for COVID patients. There's a shortage of PPE, and he's given a single surgical mask and a pair of gloves each morning and told to make Mount Sinai proud. Assuming the patients are desperately in need of such care, would it be ethical for him to refuse? You could say yes, you could say no. Like my mother, you could say psychiatrists are expendable, so it doesn't particularly matter. But the point I make is doctors do not operate in the market. Doctors are not like barbers. The only limitation on the number of barbers there can be is the number of people who are able to cut hair, willing to apprentice, pay the fee to be barbers. The number of doctors is set artificially low by the state, by the government. So doctors are more like taxi medallions, or in some communities, liquor licenses or radio waves. So maybe there is a higher obligation during crisis times to serve. But then you want to ask, what if that doctor is 60 years old? What if he's diabetic or it's another vulnerable condition? What if they don't have any surgical masks, but they do have a Batman mask? Those are the ones with the mouths that are open, and the hospital tells him to go be a superhero. Does it matter if the psychiatrist lives with his elderly grandparents or his 6 obnoxious children? Does it matter if he lives alone with his 24 cats? And since it is my field, I will add, cat ownership has been consistently linked to both suicide and mental illness. And it's probably causative rather than effect, because cats spread toxoplasmosis. That's one of my favorite tidbits. Does not mean you should give up your cat. Does it matter that I say I didn't sign up for this when I entered medical school? Or is that more like the firefighter saying I didn't sign up for this when I entered the fire department? So back to our example I mentioned earlier. So it's easy for many of you to say it's unethical, not all, but many, to take a patient on a ventilator with a C3, C4 spinal fracture like Christopher Reeve off a ventilator to help other people. But what do you do when a patient shows up in the emergency room during COVID with a C3, C4 spinal fracture? And normally we would give that patient a ventilator without thinking twice. But because we know that there are more patients with COVID who can be protected over the long haul, do we deny that patient the ventilator? That is the kind of question our hospitals were grappling with at the height of COVID. Should life-saving liver transplants be performed during a pandemic? Why? We know that liver transplant patients are immunocompromised, so they're more likely to get COVID. And since the average liver transplant patient at a major medical center will take a ventilator out of the pool for 11 days, are we, in essence, treating high-risk patients in a way that commandeers ventilators. And then you can picture an ophthalmology clinic, which treats high-risk patients, and this actually occurred in the country, where the patients are being screened for late onset or high-risk blindness. And we know that not screening them will run the risk of some of them actually developing more severe vision impairment. Should we recommandeer those ophthalmologists to provide care in an ICU or a medical unit and shut down the clinic? In essence, making a trade-off that we're going to save some patients' lives at the cost of letting other patients go blind. So I want to talk a bit about rationing, and I'm going to talk specifically about ventilators, even though there were other items that need to be rationed, including PPE. And the one that's talked about much less is ECMO machines. ECMO machines are extracorporeal membrane oxygenation, was thought to be a salvage remedy if ventilators failed for COVID. Unlike ventilators, which hospitals have dozens or hundreds of, ECMO machines, top medical centers only have a few machines. Community hospitals generally don't have any. This may have mattered in New York City at the height of COVID because there was a ban on moving patients from one hospital to another, particularly for higher level resources. So telling you how to allocate ventilators raises one set of ethical questions. Discussing how to allocate a resource we only have 2 or 3 of them raises a different set of ethical questions. It turns out that ventilators may be less useful than first thought, but probably more useful than the early studies. So the early studies said that 88% of vented patients died and another 5% never got off the vent. That's the big LIJ study. Now it may be closer to half. That's still a large percentage who don't do well. Assuming they're valuable, what criteria should we use? So the different sets of criteria used for allocating ventilators when you didn't have enough of them were either your short-term prognosis for surviving the disease and getting off the machine, your long-term life expectancy, and obviously there are significant age parameters to that. So even if your prognosis for recovering from the machine is higher, if you're 70, we might have been less likely to give you a ventilator than if you were 30 under this protocol. Your value during a pandemic, and a lot of discussion was about healthcare workers, not just to get them back on the front lines if they recovered, because if you had severe enough COVID, you needed a ventilator, it didn't seem likely that you were going to be able to go back to the front lines anytime soon, but to create a motive to keep people on the front lines, knowing that they would be protected if they became sick. And then there was a discussion, and I wrote this slide before the president got sick recently, about whether presidents or political leaders would get special treatment. And this came up in Virginia, ironically, before the governor of Virginia got COVID, over whether if the Virginia governor got COVID, he would be given special access to an ECMO machine or a ventilator if need be. Hospitals in Virginia debated this. There was no clear outcome before the current circumstances. I will mention, we do know from Great Britain that Boris Johnson was intentionally brought to a hospital with an ECMO machine, this high-level salvage care, that was not available to the average Brit. You need to ask yourself how you're going to approach the issue of pregnant women. Should pregnant women count as 1 patient, or if they have a viable fetus, 2 patients? It is interesting to note that many individuals who under other circumstances view pregnant women as 1 individual, view them as 2 individuals for this purpose and give them priority. So there is a lack of consistency. But the issue that interests me most are the equity concerns. And this is probably the hardest issue in the allocation of resources during COVID, which is if you use the system, you penalize people with what we might call pre-existing conditions or high risk factors. So you're penalizing people who have high blood pressure, who have diabetes, who, in other words, have had less access to high-end healthcare. And at the same time, we know that people who live in low-income communities, people who come from certain racial and ethnic minority groups, are shortchanged on healthcare consistently as a result of social determinants of health. So what you actually are doing is you are penalizing people a second time for things that have already affected them the first time. Now, in an equity level, that seems very troubling. On the other hand, if I told you we were going to have a holistic review or affirmative action program for college admissions or for hiring to account for people's past history of discrimination and implicit bias, many of you might find that acceptable or even desirable. When it comes to allocating ventilators and you're actually choosing between lives, it's much more harder for people to accept, even though equity may favor it. And there's no easy answer to that. I want to give you some data, by the way, just to back up my claim. So those are the old redlining districts in New York City, actually in Brooklyn and Queens, based on 1930s housing discrimination against African Americans. The red areas were areas where you couldn't get a loan. And you will see a pattern. The exact same pattern exists in segregation in schools, in income and life expectancy by neighborhood, in the presence or absence of retail bank branches, in school segregation again, and finally in cases of COVID by zip code. It almost maps perfectly, with the exception of the Orthodox Jewish communities, which have other issues related to COVID. There's a very clear consistency between low income, racial background, and it's not biological. It's, as far as we know, it's entirely social determinants of health, implicit bias, historical racism. So which neighborhoods, you might ask, lost the most people in New York City during COVID? You might guess neighborhoods like Flatbush, like Corona, like East New York, low-income neighborhoods or neighborhoods with high instances of COVID. It actually turns out that they were well-off white neighborhoods. So that is population decline in New York City, and you'll see people left Brooklyn Heights and Park Slope and the Upper East Side, not because they died, but because they went to Martha's Vineyard and the Hudson Valley and the Jersey Shore. 420,000 upper middle class and upper class New Yorkers, many of whom have not come back. We're thinking about. A few other elements to think about in terms of allocation of resources in COVID are withdrawal standards during crisis and how they apply to non-crisis. So in non-crisis times, it is widely accepted that we don't take a patient off a ventilator unless either they want it done or their family wants it done. We don't say we can use the ventilator better. Changing the standard might save lives during COVID in two different ways. The obvious way is we could use that ventilator to help other people and maybe more people if your prognosis becomes very grim and somebody else with a better shot could use it. But more importantly, we know that people are choosing whether or not to place a patient on a ventilator versus declare them too compromised because they fear that if they put them on that ventilator, they're not going to be able to use the ventilator again. And in essence, they're going to be locked into that patient. So not only might you help other patients, you might actually save patients who otherwise won't get care because they're too sick in that way. EMS rules also had to decide when to withdraw or not apply care during the height of COVID in New York City. So one rule that was established was not to bring patients to the hospital unless they could establish a pulse in the field, which is very different from normal emergency protocols. Earlier, and briefly, there was a protocol that said they shouldn't try to arrest patients at all in the field, but there was pushback from the EMTs themselves and they reversed it. And there was also talk of the universal DNR order for COVID patients, which never went into effect because the crisis fortunately abated before that time. I should also mention the issue of lack of uniformity, which is something I write a lot about, because this actually will take lives and it's an easily fixable solution. It's an example of concrete government failure. So in 2009, the government said that the United States, every state should adopt crisis standards for COVID. Who should get care in an emergency and how? In fact, the National Academy of Medicine provided very concrete strategic guidelines for how to do so. As of April 1st of this year, only 26 states had any publicly available crisis standards at all. Why does this matter? You're thinking this is hypothetical, it's abstract. I'll show you how it's really concrete. So New York State, if you're allocating ventilators, does not discriminate against dialysis patients. You're on dialysis, you need a ventilator, you get one. Kansas, you need dialysis, you're on a ventilator, you don't get one. So let us say New York State wants to borrow ventilators from Kansas because there's a crisis in New York and not in Kansas. Now, if they have the same standard, Kansas would have no reason not to give New York ventilators because they know they would get them back if they needed them. But since the threshold, the standard is much lower in New York, Kansas won't give New York ventilators, or logically shouldn't, because it won't get its ventilators back for much healthier patients when it needs them. We also need to have a system for figuring out who decides. It's probably not ideal to do in the field. You probably want to have a blinded system where a committee of evaluators shares the decision to avoid damage to the therapeutic relationship, the emotional stress of making these decisions in direct triage. We did not set that up in New York, but some hospitals considered it. I imagine if we reach a crisis again, they will. And finally, since it's been in the news a lot, I want to talk briefly about vaccination ethics. The big question in vaccination ethics is it ethical to ask volunteers to receive vaccines whose efficacy is unknown and then be infected with COVID? And then how do you compensate these people? So these are known as human challenge vaccines. The way we study vaccines right now is we vaccinate a group of people, we have a control group of people we don't vaccinate, and we put them out in the world and we see you get sick. That takes a lot of time. It is much, much faster to take a group of people, vaccinate them, and then expose them to the virus and see whether or not they get sick. On the other hand, if your vaccine doesn't work, you run the risk of some people dying. You should ask yourself, is it ever ethical? What patient population should we use? Maybe we use people who are highly informed, like healthcare workers or scientists, maybe young, healthy people who are much less likely to get sick from COVID. And then should we give them something in return, other than obviously the benefit of the vaccine if it does work? I should mention the risks of vaccine are unknown. We hear a lot of talk about how we're going to have a vaccine very quickly. I should mention that the fastest the vaccine has ever been brought to market is the mumps vaccine under unique circumstances, and it took 4.5 years. During the development of the polio vaccine, there was the Cutter episode where a failed batch of the vaccine went out to 120,000 children, 40,000 of whom developed polio, 5 to 10 of whom died. And more recently, in the Philippines, Dengvaxia was thought to be safe, but it actually produced something called antibody-dependent enhancement, which was a condition where the second time you got the disease or a similar version of the disease after the vaccine, you actually got much worse. And it was removed from the market probably after killing many people. Then we need to ask ourselves, do we test everybody to see if the vaccine is safe in all populations, or do we test it in one group and then make it available to everyone? Related to that is the question of whether pregnant women should be excluded from early vaccines or whether protecting pregnant women is worth the trade-off in risk to fetal life. And we need to decide who gets the vaccine first. So you might say you give the vaccine to frontline workers first because they're putting their lives on the line and we need them healthy. You might give it to elderly or vulnerable people first because they're most likely to die, but you also are exposing them to the most risk. Or you might give them to young, healthy people first and see how they tolerate it before giving it to others. Even if we have a vaccine by the end of the year or by the spring, it's unlikely we're going to have enough vaccine for everybody. So these questions are not going to be theoretical. They're going to be very practical. I will mention very briefly that not only is there an ethical debate, but there's a legal debate around vaccination that has largely been settled in the United States. Since 1905, in the case of Jacobson versus Massachusetts, the Supreme Court has upheld compulsory vaccination. In that case, a minister refused to get a smallpox vaccine. His objection was not ethical and it was not religious, it was actually medical. The objection was that his son had actually had the smallpox vaccine earlier and had illness as a result, but they wanted to vaccinate him again, and the court still ruled against it. The problem is you need buy-in. Why do I say you need buy-in? That on the bottom right is a picture of a priest in jail. And I always ask audiences, why do we not make priests testify to what they hear in the confessional? And the answer is not some grand theoretical answer. The answer is really, really simple. If we made priests testify to what they heard in the confessional, they would refuse to do it. And we have a lot of priests in prison. And the idea of having a lot of priests in prison really doesn't appeal to the vast majority of people. In the same way, if we jail people or punish them severely for not agreeing to vaccinate, there would probably be a public backlash. So you need to have a buy-in system to make it work. I think a much harder ethical question that a lot of us are going to face is whether or not we are going to legally require flu shots during the flu season. And full disclosure, I have argued in favor of this elsewhere. The flu shot is not as efficacious as other vaccines, but it will reduce volumes in ERs, and it will reduce the likelihood that people who think they have COVID but actually have the flu show up in ERs. On the other hand, as a trade-off for that, if people are masking, you may have a much more mild flu season, and this may not be necessary, as they clearly have had in the Southern Hemisphere. And finally, I will conclude with the following observation. And it is not about COVID. It is about preparedness more generally. That, as you see on the bottom right, is the Polish army during World War II on their way to fight the Germans. The Germans had tanks. It did not go well, as many of you know from history. I mention all this because we often fight the last war rather than the future war. And I think this is very true at present. 9/11 and the 9/11 Commission report was described as a failure of imagination. We failed to imagine what terrorists could do and how to prepare for it. Peggy Noonan, the conservative Wall Street Journal columnist, former Ronald Reagan speechwriter, has, I think, very effectively, even though I'm someone who works in pandemic preparedness, described the current pandemic as a failure of imagination. We did not really imagine what a pandemic could do and take it seriously. Why do I mention that? Because pandemics, even though they are a risk, are not the only risk our society faces. I'm going to offer you an example of one, and only one of many, just so you can think about it. So that is a picture of a schematic of geothermal weather, and solar storms or geothermal storms have the enormous potential to disrupt human life. If you doubt me, in 1859, something known as the Carrington event was the last large solar storm, and it knocked out the telegraph system in a large portion of the United States, set telegraph wires on fire, shocked telegraph operators. During Vietnam, a much smaller solar storm set off a large number of American mines off the coast of Vietnam. The estimates are that a solar storm the level of the 1859 one, which might occur every 100 years, could melt portions of the grid, kill tens of millions of people in the US, disrupt the food supply for up to 3 months, all entirely preventable with adjustments to hardware at a much lower cost. I mention that, and it's not the only example, because I imagine many of you view climate change as an important concern, and it is an important concern. But when I went around the country for a decade talking about pandemic preparedness, inevitably somebody in the audience, and I won't use any pejoratives, but some well-intentioned but misguided person would raise their hand and say, how can you be concerned of pandemics when we're all going to die of climate change or global warming? And the answer is, we need to be thinking about all of the different threats to us that are likely to occur and trying to imagine each one of them rather than dividing our interests in such a way that we don't take all of them seriously. And that is only 55 minutes. So I will pause now and I will take some questions.
Jacob, thank you very much. Very interesting discussion. I'm looking, I don't see any questions in the chat window from others, but I have a few for you.
Sure.
First off, my guess was 10 million for the ice bucket challenge. I underestimated.
I mean, you were close. I mean, a lot of people get much higher, so I'm impressed.
Okay. I do have a very nerdy question going back to when you had the chart, the micro allocation chart. There were 2 lines, a red line and a green line and a blue line. Was that just different ways of looking at it or different?
There are different measures of looking at it, and I don't recall offhand exactly what the metric used is, but they're in essence, they're mathematically different, but principally the same.
Okay. Second, another question I had was when you talked about, and I probably have the name wrong, but a uniform standard of care. Why was there such a pushback about enacting that across the nation?
I think partly there's just been a general lack of cooperation among states. I think part of it reflects the political polarization of our society. And part of it is that a lot of decisions have been made by people who are not experts in the field. I think if you sat down experts on resource allocation and asked them to design a system for the nation, there would be very little disagreement, even among those who are very conservative and those who are very progressive. I think when you take it to the political arena, there's suddenly much more disagreement.
Okay. Another question I had, and then we'll get into some other questions that have come in. We talked about the ethical considerations of doing a challenge study for vaccine. To a certain extent, don't you run the similar ethical questions with a double-blind study and putting people out in the wild with whether they don't know whether they're protected, whether they have the vaccine or the placebo?
There are similar concerns. I think the difference is that in one scenario, there's a possibility they'll get the disease, but those patients can still take all sorts of precautions to keep themselves from getting sick. So we can give you the vaccine, which may protect you, but you're going to socially distance, you're going to wear your mask, all in your power. If we put you in a room with the COVID, we're in essence guaranteeing that if the vaccine doesn't work, you get sick.
Okay.
So it's a continuum. It's not a difference of kind. Good point.
Okay. Now, a question from Andrew Riley. It's a comment, and it's easy to raise ethical questions, but it is rare or absent that ethics provides an answer. It says this talk too was, I do appreciate, but there's not a lot of answers as to what some of the solutions are. What gives?
Sure. So I'll offer my general thoughts. So my talks, unlike my work in the hospital, is designed to generate questions because I think a lot of people simply aren't thinking about these questions in these terms, and I like to get people thinking about them. I think the best way to come to answers for these scenarios, because there usually isn't a right answer with a capital R, is by consensus building among experts and stakeholders. That's how the hospital makes ethical decisions in general. For non-COVID, non-crisis cases, families want a recommendation in a particular crisis. We don't ask one ethicist to offer them an opinion from on high. We get different people from different backgrounds, nursing, social work, surgery, pediatrics, all to weigh in and try to see where the common ground is. I think one of the problems in ethical management, particularly with COVID, is there has been very little meaningful effort to build that common ground. I will add, and this is not more a general political comment, but a specific political comment. I do think it is unfortunate that this is the first presidential administration in many years not to appoint a bioethics commission, because that has sort of taken away one of the best spaces for this debate to occur at the highest levels.
Okay. I have a question from Andy S., who asked, what have you concluded and would recommend on medical rationing?
Sure. So I think the most important thing people need to understand is that rationing already occurs, and it already occurs on a large scale. It just occurs invisibly. And you could design a system where there's no rationing at all or no meaningful rationing by spending half of our GDP on healthcare. And if we had, for example, a stockpile of 200 million ventilators stored away, none of this would be an issue. But the trade-off would be you would go to the store like you do in Cuba, and rather than being able to buy Colgate or Crest, you would see one vial called toothpaste and buy it with your ration card. And most people are unhappy making that trade-off. So if we're going to ration, my advice would be you want to ration rationally, at least up to the point where the political will can accept it. Most people won't accept being told that if they have a 19% chance of surviving cancer, but the money can be spent elsewhere on flu shots or mammograms, that the money should be spent elsewhere. It's just not something people will accept. On the other hand, many people will accept being told in advance that there is a cutoff for how much money they can get in the healthcare system, knowing that it benefits them in other ways all along.
Mm-hmm.
I have a question. Can I ask my question verbally?
This
Sure.
is Barry. Go ahead.
Yes. I'm interested in Josephus, the ancient historian who apparently used epidemiological methods to decide how many Jews died as a result of the revolt and the reaction to it. So was he using accepted epidemiological methods, and do you think they were effective the way he used it?
I know of Josephus. I don't know the exact anecdote. Can you run that by me one more time? Because it sounds like something I don't want to say the wrong thing to.
He tried to figure out the effect of the revolt on the Jewish population by looking at the grain supply coming in from Egypt and seeing the change in the amount of food that was consumed. This to me is a statistical epidemiological method. Am I right about that?
Yeah, I mean, it is empirical evidence, absolutely. I mean, one of the questions we need to ask is there are some studies that we can do that maybe raise larger ethical questions that we want to step back from, but statistically, it seems plausible.
Okay, thank you.
Okay, Fred has a comment, question. It has appeared to Fred that over many years, the problems in healthcare are due to political interference. Do you have any thought on how to get politicians out of healthcare decisions?
No.
Oh, I wish I could answer that one. The only thing I can say, and I know this is a very unpopular view, but I do think there should be more healthcare and bioethics education at an earlier level. My experience has been that most high school students coming into college, except maybe from top tier private schools, have no exposure to basic questions in how the healthcare system works. And I think even a basic level of understanding for people who aren't going out to college would help them a lot in making decisions. I don't think that the average voter really has an understanding of what a single payer system is, how Medicare works. When somebody says something like, get your government dollars, get government hands off my Medicare dollars, it shows there's a problem with how people see the system.
Mm-hmm. Yes. Another question here from Olga Porterfield. If we learn to consider all catastrophic scenarios, wouldn't it cause a pandemic of depression?
That's a really good point. I will add right now, there is a pandemic of depression. I can say that firsthand from my work in New York in the emergency room. I think there is a mental health crisis of unprecedented proportions, at least in my lifetime and certainly in my work. And another area where I do some research in, which I think people have lost sight on, is there is an epidemic of loneliness in the United States, as well as in Western Europe and developed nations, and the health consequences of it are staggering. There is significant data to suggest that significant loneliness among older populations is probably as deadly as smoking, as drinking, as many other of the lifestyle choices we try to change. And yet there's very little attention paid to it, at least until recently medically.
Okay, thank you. Another question here from Jane Lax. Would lifetime expenditures play some factor in rationing?
So you could set up a system where we cap the amount of money you spend in healthcare over the course of your lifetime. The downside of that is you will have people who are very provident, so to speak, who try to save money in the short run, thinking they may need it in the long run, and not get the kind of preventive services they need. So the alternative approach is not to cap overall care, but to cap catastrophic care for particular events. Slim Watson's case being a paradigmatic example, where we say, if your medical care costs more than $5 million, which is not an excessive amount to draw the line at, then we need to start looking at how much care we're really going to give you. The problem is Slim is a visible victim, and people feel very uncomfortable withdrawing care from people who actually can go on television and make their case.
Mm-hmm. Okay, that's all the questions that have come in chat. If anybody else has a question, you can unmute yourself and ask. Okay, Barry, can you unmute yourself or?
Well, I think that doctors are currently practicing rationing anyway. They, by their own assessment of how long you have to live or how much care you provide less care to older people, and actually do that openly. I've heard many anecdotes about the fact that doctors consider people at 90 or 100 not worth all the care, even minimal care in hospitals. You could comment on your reaction or your experience, but that's been an experience I've already had.
Well, I can say I hope that's not happening.
It is happening.
Yeah, I don't doubt your experience or what you've heard. I can tell you that it's not happened in my experience, but obviously ethically that should not be happening. Age should not be the factor in making medical determinations, and people should be able to make their own medical decisions. What might matter, and I think is important, is we should make people aware of what their prognosis is, what their condition is, what their costs are, in fact, so they can make their own medical decisions. I think one unusual but interesting area where this came up very concretely was the question of whether or not people should be able to turn their life support off or to take advantage of the Bush tax cuts before they expired. And it actually became a boutique industry for a law firm in New York City. And it's a really good example of how individuals might have made their own determinations about health in ways that other people or society as a whole might not have, to ration against what many might perceive as their own interests.
Andy, you had a question?
Yeah, on keeping drug prices down, Trump recommends giving the U.S. Most favored nation status, getting the lowest price that is charged to any other country. And Biden recommends a drug review panel that will review the developmental costs of any drug and give them a cost plus profit on it. What do you think of those two plans?
The short answer is I think they're both good ones. And I don't think there's a trade-off between one or the other. And I think one of the problems with American politics is everybody has their own plan, but we could embrace both plans and they would feed off each other.
Okay. I see Aya has unmuted. Do you have a question, Aya?
Yes, I have two. I have one about the profit grounds of United States healthcare. What do you say about that? You mentioned that 17.9% in 2019 was of GDP was used for health cost. But then, like many European countries and Scandinavian countries, it was around 10% or something like that. But they operate in totally different, as far as I know, they are not seeking profits for healthcare. And then another question, what do you think? And I like that when you say, you know, that we have to ask good questions. That's very important. And the imagination for future. So what would you think that would be the one of the most pertinent critical questions to ask right now?
Sure. And I think I'll answer the second question first. Because I think the most important question, it is very clear to everybody, I should be very clear to everybody, that eventually we will get through this pandemic as a society. We will either develop a vaccine or we will get the R0 below 1. The question is what we are doing about the next pandemic, because the next pandemic could be more infectious, the next pandemic could be more lethal. If a more lethal or more infectious disease had arrived on our shores in January with our current level of preparedness and response, I would suggest we would not be having this conversation right now. So it's easy to say we beat the pandemic, we win. I think the answer is we beat the pandemic, we lost. How are we going to win next time? And your first question is also a really good one, which is how do we compare our system, which is largely a for-profit system, against the European system or systems that are not? And we know that about a third of our healthcare dollars are spent in some form of management, which is, there's no management in Europe, but there's much less management or much less of a middleman. Even taking that out, we're still on the higher end of expenditures. And obviously you could take that out with some kind of uniform healthcare or single payer system. We'd still be spending more, so it's impossible to make a real comparison. We'd have to actually spend less money per capita in a national system to get a meaningful comparison. Part of that, honestly, is because there are a lot of factors related to European cultures and society, homogeneity, the equitable allocation of resources, basically make the culture very different. And that plays a large role that we don't talk about very much.
Okay, I can go back to, I'm sorry, Aya, go ahead.
Just an excellent talk. Thank you very much.
Thank you.
Go back to the chat. We had a question that came right in along the same lines. Samuel asked, when discussing costs of healthcare, including hospital stays and pharmaceuticals, how much of these costs is profits for stockholders or board members? And I think you touched on that briefly in your response to Aya.
Yeah, so we know that a third of the expenditure is spent on what we would call middleman or administrative. It depends what you mean by profit. So since it's in the news, I can mention this. So last year, the president CEO of my hospital made $12 million a year. I have gladly offered to do the job for $6 million a year. They have not accepted my offer yet. But I make that point because that doesn't play out as a profit, and it's not money given to a board. It's simply money distributed to senior executives, and you'll find that at many hospitals, and you'll find that senior surgeons at major hospitals make an awful lot of money. So it is rather a widespread cost distribution at the higher ends of healthcare. And you have to track all of those shoots from the branch in order to get a real concrete answer. To my knowledge, nobody's done that.
Okay. Andrew Riley said, fantastic talk. Thanks so much. Where can we find your writings?
So the short answer is I put my email in the chat box. As
Okay.
many of you know, I run the creative writing program at Mount Sinai as well. I am glad to send you complimentary copies of my novels, my recent Simon & Schuster novel, that are often set in the healthcare setting for free, PDFs, electronic books. Just feel free to send me an email. I can try to see if you email me if I can get you a free PDF of my latest ethics book. I can't promise, but I will make an effort if you send me an email.
Okay. Well, we'll make sure we get your email address posted to the group of people that are on the call.
Sure.
Mrs. Levine asked, or actually made a comment, medical profession has been making unofficial ethical decisions from the beginning of time. You think she raised many in-depth considerations that speak to complexity of ethics in medicine.
Thank you.
Jane Lax asked, building on Sam's question, is capping profit margins a viable option when considering rationing?
It's certainly a viable option. I have learned not to endorse particular solutions of that sort. I will leave that for the political process. But it is certainly, there's a system you could design to do that. And the issue that arises is whether investors will put their money into pharmaceutical companies versus soft drink companies or tobacco companies. And you might have a shortage of capital at that end. But I can't give you a concrete answer on whether there would be.
Okay. I saw Bob Bosca had unmuted himself, then muted again, but I see somebody else says, Bob, do you have a question for our speaker?
Yes, it was kind of long to write in the chat, so I gave up on that. Given that triage decisions are complex and that the social systems behind them it's a complex system, that complexity science has been advancing and developing better ways to model decision making. Wouldn't something like an AI paradigm for inputting all the data about a patient, their situation, every known correlation with outcomes and even population statistics, make a better decision making than human beings who would have some tendency to have at least some emotional input that is not just judgmental, but is judgmental in the bad sense?
So that's a really good question. That actually is a question that people have discussed very actively, because what you want to avoid is the individual provider in the field making decisions that reflect implicit bias or factors that shouldn't play a role in clinical decision making, with the caveat that having been a physician for a long time, there are sometimes you see a case and it just feels different from other cases, and you
Yeah.
can't explain why, and you don't want to lose that. The idea of having blinded panels where others are reviewing the chart, doctors who are not actually seeing the patient, has the upside of trying to remove some of that bias. You remove, for example, racial age data from the chart. The problem with that, beyond simply the practical element using AI, there is an optical element, which is that if you tell people a panel of doctors has reviewed their chart, they may not like the outcome, but they can swallow it to some degree. If you tell people that a computer has decided they're not getting a ventilator, there will be a large-scale public outcry. But it's a really good point.
So you don't think people will like the God computer?
I am highly doubtful, but.
Okay. Had a comment from Olga. Thank you very much. And then a question: where and how can we watch the documentary about you entitled Jacob?
Sure. So I will confess, I have not actually seen this documentary. My understanding is that several million people have, but I am not one of them. It was directed by John Stahl, and I believe it is available on Amazon Prime.
Okay.
And possibly a few other of these sites like Netflix, but I don't recall which ones.
Okay. Thank you.
My guess is I've seen it because you are so familiar to me, and I can't place why. I must have watched your documentary.
Jane, it'll reassure you that happens in restaurants all the time. People come up to me and say, "You, the guy behind the mask," which is not reassuring.
Mm-hmm. So Jane also had a question in the chat. Do you have data on the variance on profits of healthcare goods and services between other countries?
Yeah, I'm asking that because you show the graph of, percentage GDP. Are we getting a higher level of care, or are people making more money? Or is it both?
The answer is both. I don't have the graph in front of me, but the answer is we are getting a higher level of care and people are making a lot more money.
Thank you.
Rosina, you wanted to ask a question?
No.
Okay, I saw you were unmuted, so
Oh, well, I did unmute myself. This is just more a comment that I really want to go and watch this again on Facebook, because I had so many of these oh moments during this, because I thought, well, there's something I had never thought of. So just thank you, because it's really worth watching again to see all the different issues.
And I put my email in the chat box. If people have a question they're burning to ask that comes up to them next week, they should feel free to reach out.
And to your point, Rosina, we will post a recording of Jacob's presentation on our YouTube channel, and we will send a link to all the members and everyone on this call, so that'll be available. And we'll make sure it includes Jacob's email address. Fred had a couple questions here. When you work in the ER at Mount Sinai, are you working as a general physician treating COVID patients, or are you doing psych intakes? If you are treating COVID patients, how do you feel about that?
Sure. So I'm supposed to choose my words I say actually about Sinai very gingerly, but I will tell you.
Because you have to make them proud, right?
Yeah, exactly.
Make them proud.
I do like my job. I'd like to keep it. But no, so I am a psychiatrist and an emergency room psychiatrist. So my encounters are doing consults for patients who have COVID, either in the emergency room or on a medical floor, who also have a psychiatric concern. And that could be one of two situations. It could be a patient who has a severe mental illness, like schizophrenia or bipolar disorder, who also develops COVID, or it could be a patient who develops COVID and as a result of that leads to a psychiatric consequence, like they lose a family member and become depressed, or they test positive and they become anxious. So it's two sets of patients.
Okay, but then how do you, I guess you feel about that, you got to do Mount Sinai proud.
Well, I always tell people I have nothing to complain about because I haven't gotten COVID or haven't died of COVID at least, and I haven't gotten fired. So I'm ahead of a lot of people. But I mentioned beyond that, I think like anything else, you take the appropriate precautions, but eventually you get used to it. The hospital becomes your norm of life. You use your PPE, you treat the patients the same way with the same safeguards. I think it's very striking that when they did the antibody testing in New York City, that healthcare workers actually were less likely to have had COVID than non-healthcare workers, which does not suggest less exposure. It suggests that either more available PPE or more education and skill in using it, but certainly a deeper commitment to keeping safe.
Mm-hmm. Okay, thank you. That's all the chat questions from chat. Are there any other questions anybody has?
Yes. We've been talking about the healthcare system, and the question of the quality of care has to be read over the entire population, including a lot of people who don't get care or go to emergency rooms. And by that standard, I don't think the United States comes in that high. But the specific question is, a statistic came up, I heard it was astonished me, said that the United States has a total of 900,000 hospital beds. That may be wonderful if you're not needing the whole population, but apparently Germany and even England have done better because they have a lot more beds. Does anybody know what the ratio of hospital beds to population is here compared to other countries in Europe?
I don't know the number offhand. I will suggest that while hospital bed numbers matter, it's not clear that having more hospital beds leads to better healthcare.
True.
There's a healthcare economist, Milton Romer, who in various ways has demonstrated that if you create more hospital beds, it leads to more hospital admissions because hospitals obviously want to make more money. And because there's a iatrogenic death or hospital-related, doctor-related death is the fourth leading cause of death, you actually make people sicker over a certain tipping point.
Really? Okay.
Yeah, so I don't know where that point is though. We may be behind it. I just don't know.
Right. I guess the other question is about elective surgery. Some people think we do elective surgery quicker in this country, but it's also the chief profit center for hospitals. Elective surgery could be done more in this country because it's profitable and it's a for-profit system. And I think doctors do tend to overprescribe a lot of procedures, even if the stuff in the literature says no. So my question is there any comparison about elective surgery in this country and other countries that don't have a for-profit system? The amount of elective surgery that's done per population.
So the short answer is there's more of it, but I can't give you the exact numbers offhand, but they are available.
Okay, thank you.
Okay, that was, again, I have no chat questions. Does anybody else have any other questions?
I would have one question.
Go ahead.
Yes, that from an ethicist point of view, how would you talk about, or what's your opinion about herd immunity? Because I know from Scandinavian countries in comparison, Sweden has had a dismal results of their COVID approach, and they propose herd immunity.
So the best answer I can give you is eventually we as a society will inevitably reach herd immunity. We will either reach herd immunity because we develop a vaccine that puts us over that tipping point, and we don't know where it's going to be, 50%, 70%. There are a wide range of estimates. Or we will have a porous system where enough people get infected over time, and eventually we will reach herd immunity. There are two different theories that have been proposed, one which are viable. There are a lot of proposals that are bad ones, like simply letting the disease spread over the entire population. One approach suggests what we're supposed to be doing now in the US, which is using masks, social distancing, trying to get the R0 below 1, and eventually having the disease die out. The other approach says we should sequester people who are older, more vulnerable, and then encourage the disease to wave through the rest of the population quickly to achieve herd immunity. If you believe in human nature in a positive way and the efficacy of government and the goodwill of people, the first way is a much better approach. However, to be very cynical, if you believe that human beings are simply incapable of doing what they're asked to do, and that our society is so broken that we're not going to be able to achieve those goals, then the second approach makes more sense than simply letting the disease wash over everybody and kill more vulnerable people. I will hold judgment over whether I think human beings are good or not. I can tell you the last 6 months have not reassured me on the ability to achieve what I was hoping for at the outset.
Thank you.
Thank you. Jane, did you have a question?
No, I just wanted to thank Jacob so much for this really dense, wonderful, thoughtful presentation. It was fabulous. Thank you.
It's my privilege. Thank you for inviting me.
Oh, I want to add my thanks too, as well as everybody else's. I appreciate everything you did. Very insightful, raises a lot of good questions. So I do have another question here that just came in. Was the test for COVID-19, what test for COVID-19 was used the most for the overall counts?
I actually don't know the answer offhand, which there different states and different hospitals use different testing. I just don't know the data. I'm sorry.
Okay. Olga also said the documentary about you is on Amazon Prime, and she went and found it, so started watching it.
I already watched it, I'm sure.
I hope it's good.
Well, you don't want to see your own. You don't want to see your own rep, right?
You definitely, my understanding is my parents are on it and I love them dearly, but don't want to know what they said about me. So,
Okay. Okay, well, we do thank you for your coming with us today and coming to speak to us. We do appreciate it all.
thank you all very much.
And I understand you have to get back to work shortly.
I'm going back to the hospital as soon as we're done.
No, we should let you do that then. Thanks again.
Absolutely. Be well. Stay safe, everybody.
Bye.